else on at this point, please sign into the chat. That will be my documentation for PACE. And I greatly appreciate that. Well, it's 12:04. Maybe I'll give it one more minute and we'll get started today. As people join in, I'll mark them later. So, were there any questions from last week? We essentially hit biosafety. I thought that Hannah Krieger had a really good question. Wonder if any of you could answer this question. Why is centrifugation an aerosol? And what would you say? I'm going to open it up for conversation. What would you say about why centrifugation is an aerosolization? Because you would think that as you're centrifuging, it would pull everything down to the bottom. Would you think that that's sufficient and therefore it's not an aerosol? Do you think it's an aerosol, and why? So I'd love some feedback. Don't be shy. Just unplug or unmute and you'll be fine.
I would think it would definitely be an aerosol if it breaks or anything.
Yes, and if you think about it, centrifugation is very hard on a container. You know that after a container gets older, it starts to crack, especially the plastic ones. So the chance of it breaking is greater. That is why they recommend that you have the type of centrifuge that has a cap that can, or a screw top, what they call that rotor that can be enclosed, and that is what is recommended they take out of the centrifuge and take to your biosafety cabinet. So thank you for answering that. I agree. And two, I think that the centrifugation alone, yes, it might pull it down, but what happens then, it creates a suction at the top. You've got a vacuum. If that happens and you go to open your cap to your centrifugation tube on the open bench, that might pull anything out that is aerosolized. So if you are on the open bench, you may be at risk to that aerosol. Again, why we recommend it be opened in a biosafety cabinet. All right. So to go on, I am going to go ahead and just back up one slide. It was as a quick review from last week, why we watch and use competency to find out what biosafety measures we are following. Ultimately, we do want to prevent those laboratory-acquired infections. So obviously, we want to wash our hands frequently. You've heard it all before, I'm sure. Especially keep your hands away from your face, cuts maybe on your cuticles or on your hands. Make sure they're covered with bandages. Definitely avoid personal items in the lab, and we're talking specifically about probably pens and cell phones. Do not sniff plates. There's the recommendation that you can keep the lid on the plate and sniff that way, but taking the lid off is a no-no. Also, to work the most obvious things, fungal, TB, those must be performed in a biosafety cabinet. And obviously any aerosol producing item like centrifugation, that rotor needs to be open in the biosafety cabinet, as we said. So any potential organism, the soonest you recognize that trigger point, we ask that you move it from that open benchtop that most laboratories unfortunately have to work on, and at that first trigger point, move it to the biosafety cabinet. So today we're going to go on to a lot more about the rule out and refer. We're going to demonstrate how it works today. We're going to also go through some of the resources that you can use, especially the bench guides that are available, and show you how to follow a flow chart. I think as microbiologists, sometimes we're very set on following big charts, you know, those kind of charts that show the organism and every biochemical you could possibly test. And that is not what we want for the rule out process. We want to be very streamlined in what we do. We want to be very careful in what we do. We want to very much limit the type of testing we do and limit it only to those tests that are on that flow chart. So we are encouraging laboratorians to only use the flow chart instead of this big ID chart that you might find in some of the big books. We'll talk about who to contact when you cannot rule an organism out. We're going to mention very briefly about packaging and shipping, and then also what are the requirements to report a hazardous organism if it truly has been identified and confirmed as a hazardous pathogen. All right. So as we mentioned before, the LRN protocol really is designed of a few few minor tests, usually rapid type of detection, the gram stain, the oxidase, the catalase. We look at hemolysis. That helps in figuring out if there's a trigger point. We look at motility. Unfortunately, motility, this is not the drop, the hanging drop. This is looking at a motility tube that you have to incubate for 24 hours. Same way with the urease. Some of the organisms act fast with the urea in the urea tube. However, some of them you have to let go and incubate for a full 24 hours. Beta-lactamase, however, is a rapid test. So we want to confine it to just those tests, use those in our protocol to either rule in or rule out. So in other words, if a laboratory cannot rule out an organism by just those limited tests, we would prefer that you discontinue working on the organism and then refer all the suspicious pathogens and isolates to the public health laboratory. We do have the ability with a BSL-3 laboratory to work on that organism, so it will immediately be taken into the BSL-3 and we continue its workup. So obviously the key to recognizing trigger points is to recognize them early on, hopefully, and that leads to timely notification and to prevent exposures to you. The earlier we know, the less exposure risk it is to you as a laboratorian. So our goal is to recognize that trigger point. Now, these LRN, known as laboratory LRN is spelled wrong, sorry about that, but our laboratory response network, these guidelines are not just Nebraska guidelines. These were formerly maintained by the CDC. As we said, it came about back in 1999. ASM worked with it, the FBI and APHL also worked with it. The CDC no longer maintains those protocols, so therefore the American Society of Microbiology is managing those, and it can be found on that ASM website. Unfortunately, you have to kind of drill down quite a ways. So we recommend what you can do is simply go to our website, and as you see here, that the, let me try to get my, arrow up for annotation here. Ah, no, I didn't get it up. Oh, sorry about that. But anyway, you can see this arrow here pointing right toward our website menu on the left side. And there under preparedness is both chemical and biological. It would be under the biological section that you want to click, and all that information is right there and directly associated with ASM. So when ASM does update that link, it will be updated on our website as well. All right, we have created a just-in-time bench guide. It is very minimal, created 7 years ago. We hope here in the future we can do some updating because there's been some changes to our LRN protocol. We also could recommend the APHL Quick Guide, a lot more involved, but it might not be a bad thing for those laboratories who are much larger and have better capacity to do more biochemicals. You will see that some of the more specific biochemicals are still recommended, like PC Yager or Thayer Martin. And therefore, if that is something that your laboratory has, you're welcome to add that to the rule out and refer. Again, though, we've tried to, with our NPHL guide, to keep it very simple, to know that a majority of the laboratories no longer handle a lot of the specialized media. In fact, unfortunately, no longer do they many times have motility or urease for that matter. So those are two very integral pieces of media for the LRN, and that is why the Nebraska Public Health Laboratory continues to home make motility media and purchase urea media, and we provide them for all of you so that that is readily available if you have a suspicious organism. So going on, the other book that I can recommend is something called the Clinical Laboratory Preparedness and Response Guide. Now, if you've been in microbiology a long time, you might realize that at one time it used to look like this. It was called the Blue Book. Essentially something that CDC sent out back in the late 90s, probably early 2000s, when they introduced this whole program. And because of that, because of the age of it, about 2 or 3 years ago, we have gone ahead and updated that book. The CDC has put it out. However, they have not made hard copies, and that's because it's over 300 pages long. But you will find this on our website, and it is a great resource. Not only does it include a lot of detail about each of our organisms, but it includes the shipping, packaging, and shipping information as well, very much in detail. So again, on that NPHL website, other things that we provide are the BT media procedures. If that is not a procedure or a media you use in your lab, for instance, if you no longer use motility, you may no longer have the procedure. So I recommend you pull that procedure down. It's really just a template that you can add your own laboratory name to the top and use this as a procedure for inspection purposes. We also have category A and B shipping procedures available. There is something called a BT readiness procedure that I'll show you in a moment, but that is designed to be the LRN protocol in a hard copy, and that also should be in your SOPs, in your laboratory manual. Again, designed as a template that you can simply add your laboratory name. The CDC forms, if you are asked to fill these out, they will be readily available on our website. And I have articles and case studies listed there that used to be in my notebook that was handed out. And to share with you that those notebooks are getting old enough that I fear there's some unusable information on there and have tripped up laboratories at some point. So I recommend really going through that and throwing it away or discarding that notebook, and just so that laboratorians know that it is all within our NPHL website. You could bookmark it, earmark it, so it's easy to reach. I also want to bring your attention to what we call the reportable disease chart that is available on our website. This is literally a state regulation. It is approved by our state legislature that all laboratories are required to, number one, report the organisms on this list, and two, that they literally have to send in the isolate to NPHL if you find it in green. So obviously all the BT organisms listed is required to be sent to the public health laboratory. We have a few shipping guides. What we've done is divided them into two shipping guides. One for those laboratories that do cultures. So if you have a microbiology lab and you are doing specimens and testing that is culture dependent, please make sure that you have this posted at your micro lab so you know what organisms to send to NPHL. Because that's what I've done is I've kind of extracted all the ones that have to be sent to NPHL, and you know what to ship to us. It is also a good guideline to know if you need to call the state immediately. In reality, you actually call your local health department, who calls the state. And then we would go ahead and tell you how to ship if it's category A or B, and any additional notes that's needed. We also have a chart for laboratories that may not have microbiology departments in them, but they are taking up the BioFire, the Cepheids, and all those PCR testings that now identify some of these same organisms that were done in the microbiology lab. They may not have the ability to culture, but we ask that you send it to your reference laboratory to culture or to send to NPHL so that we can recover that organism. All right, any questions before I get into that? Well, let me go on before I do questions. The BT readiness procedure, I just mentioned it before. And so the BT readiness procedure looks just like this, that you can pull from our website. You would add your facility name right there in yellow, and it's in the format that allows your lab to be accredited. So with that, this is your hand procedure that you can use for your laboratory manual. So with that, do you have any questions here at this point? And you're welcome to type them into the chat. I'm trying to keep an eye on our chat box as well. Okay, I don't see any. So a good review for those who are not as experienced. The oxidase test, there are several different types out there. We do recommend the old-fashioned method simply because we feel that is the most accurate. People do like to use the swab or maybe some of the newer products that are oxidase sticks. But if you do the older method, it uses that grade 1 filter paper. And keep in mind, it's really easy to flood the result. Like if you put your organism on the filter paper and take an entire drop, of oxidase reagent, you could drown out that positive result. In fact, I recommend drawing a line all the way across. So as the oxidase tends to diffuse through the paper, it gets to a point where it's a happy medium, and then you can see your positive result. That seems to be the most subjective test ever. I have a lot of variation in results as we compare our LPXs and our challenge sets. So I always tell people to make sure and do your QC organisms as you're doing your oxidase, especially if you don't do QC on a daily basis. Some laboratories do at this point, but if you are not one of those laboratories, make sure that you are doing QC along with your unknown. 2-catalase is also recommended, at least for these organisms. I am not saying that for every catalase that you have to do the tube, although we know how aerosolizing that test can be, and all the air bubbles that do come up leading straight to your nose. So I would recommend that you be very careful if you're going to do the slide method for just your middle of the road organisms. But if you are suspecting one of these organisms, definitely make sure, number one, you do it in the biosafety cabinet, and number two, even in the biosafety cabinet, I want you to learn how to do the 2-catalase. Another test that's optional is indol. We do have some of the LRN that we recommended. You are welcome to use your regular indol. However, the spot indol, which is the cinnamaldehyde, and that if you ever request more media or reagents, that is what I can provide for you, is that spot indol. Just let me know if that's something you don't carry and you would like us to provide. Do know that the color is different for each of those type of tests. The positive is blue for the cinnamaldehyde and not red like you would think for the COVAX reagent. Indeed, it's actually a negative result for the cinnamaldehyde. All right, India ink, the old wet preps are totally discontinued. We now see that CDC does not recommend doing the hanging drop anymore, or anything that could subject you to possibly touching these organisms. Motility, we provide a very semi-solid clear media, which is a little bit different than some of the commercial medias out there. Unfortunately, they seem to be much more cloudy and very subjective to read. So this is something that we provide for you. We make on a biannual basis, and we do send out. I believe they are coming due very soon, and we're going to see what we can do to get those replaced. All right. So let's think about trigger points. There are probably a million different trigger points you could try to memorize, but I don't, in this day and age, for the amount of work and workload that you have to do, we don't want you to memorize those. We only want you to memorize 2. And without fail, that anything that is a rapid grower, like it's a lot larger than it should be at 8 to 12 hours, and if it's gram-positive rod and non-hemolytic, anything of that sort, you will want to definitely immediately, even before gram staining, in reality, so you'll have to go just by the colony morphology or the direct gram stain when you're looking at the specimen, and take it into the biosafety cabinet. You will also want to, anything that does not grow at 24 hours. So anything that does not grow at 24 hours, but maybe you have growth at 48, don't even question it. Please take it into a biosafety cabinet. If you think it's Haemophilus influenza and it's just growing slow, don't question it. Please take it into a biosafety cabinet. Other things that we'll work through that might be a hint or a trigger point. No growth on the conchies. I also recommend highly that if you see in any sterile site in the direct gram stain, so as you're the next day looking at your report, hopefully that is a good habit you've developed, is to look at your gram stain report first before you even open the plates and review that gram stain. If you see gram-negative diplococci or coccobacilli on it, I highly recommend that you work that specimen up in a biosafety cabinet. So how does the LRN protocol work? Really what it does is it first starts with your gram reaction. So if it's gram positive versus gram negative rod versus gram negative coccobacilli, those are basically the three areas. So we recommend that at the first onset of realizing you might have something, we want you to go to the bench guide to review what you have to know about your gram positive rod or your gram negative rod as you consider it. We will have in detail in the summary page of the guide the detail about the gram stain. You'll see here with the gram positive rod, we talk about it as a large gram positive rod, maybe in chains, that it might have spore, I'm sorry, not spores, capsules seen in the direct clinical specimen, and that the gram stain of the culture may show subterminal spores. And may easily be decolorized. So these are the things you need to recognize. We also then put what the gram stains look like. So we have thumbprints there to help you visualize it. We have a few interesting tidbits about what you'll see with the specimen itself. For instance, if you see that usually spores are not seen in patient specimens, but they may be seen after extended growth on your plate. So just some reminders about how this particular organism reacts. And the same goes true with your gram-negative rods, because if you suspect a true gram-negative rod, you are probably thinking of a Burkholderia or a Yersinia. And going back to the gram-positives, you're probably thinking of a Bacillus anthracis. If you have a gram-negative coccobacilli or a gram-negative small rod, then you are in need of ruling out Francisella, Brucella, or B. mallei. So those are the only organisms. If you can rule those out, you should be able to feel very confident in working on the open bench. All right, so I just want to make an example of one of these. So rather than telling you what it is, we're going to pretend you are on the bench and on blood culture bench, and that you have a blood culture that flagged positive, let's say the evening before, it was subcultured to blood, chocolate, and McConkey. So you're assigned the next morning to the blood culture bench. And what are you going to see? Before you even open up your plate, we're hoping that you look at your LIS computer, that you review some documentation. So what should you be reviewing on that particular requisition? What are some facts that would be helpful? Well, how old the patient is might be of use. Emergency room at the location. Say it's is the patient emergency room, or is the patient in ICU versus is the patient in the clinic and has probably been dismissed to go home. If that patient's in ICU, obviously it's a much more serious situation. We recommend trying to investigate what the diagnosis might be or the history of the patient. And I realize that is not information that a physician always shares with you. Sometimes your requisition does not have this, but do know, especially in SunQuest and Cerner, I do know there's a way you can program it into your screen. So ask your supervisor how to do that, because I know that when I worked with those two settings, I was able to see a patient history or the doctor's diagnosis, and that was quite helpful. The other thing you really want to observe is the date and time of collection versus what time it became positive. So if you're talking that this specimen was collected, let's say 1 o'clock in the afternoon, and then by 2100 the bottle turned positive on the same day, that should be a clue that your organism is a rapid grower. Most organisms wouldn't grow in a blood culture at least 20 until 24 hours, sometimes even 48 hours. So with that, you're going to review what was on the gram stain. Now, normally something would be typed here because they would have read it the night before, right? Okay. Well, I'm going to have you guys guess it or tell me what the evening person reported. So please share with me how you would have read this gram stain. Don't be shy. You can put it in the chat box if you'd like.
Well, it looks like large rods. It looks gram negative.
Yes, very true. Thank you for that. It does look like it's gram negative. However, if you are very used to looking at gram negative rods, you also know that gram negative rods usually aren't quite this large. That might be a clue that something's wrong. Or if you happen to notice that there's a clearing around the rod, that might be a clue that this is not a gram negative organism. So there are some trigger points we want to consider. Go back, think about what site it is. Obviously, this is a sterile site. You look at the symptoms, and that particular symptom was abdominal pain, diarrhea, high fever. All right. And rapid growth, you've been able to figure that out due to just looking at your collection time. And you're noticing large rods. In fact, they're awfully large to the point where they're almost perfectly boxcard shaped. So hopefully that is another clue. And for the fact that it is red and not blue, like gram negative or gram positive organism should be, you know that this is an organism that has been easily decolorized. So with experience, you learn that the decolorization is a trigger point, and also that encapsulation or that ghost look or that clearing around the organism could be encapsulation, which happens when you have certain gram positive rods. Okay, now let's look at the plate itself. Now that we are done looking at our requisition, let's go to see what what might be up as far as the colony morphology. So if you think about it, they sub that organism say later in the evening, And here you've got good, very good growth, this size growth with what, 8 hours or 10 hours, 12 hours. And you look at it first thing the next morning. And that colony morphology is very characteristic, but you won't always see this characteristic at first. Sometimes it isn't always obvious because maybe there's too much growth. What is notable is that it's non-hemolytic. So you see a colony that is rough, irregular, it's flat, but yet the edges are very irregular. This is what they might call that ground glass look. It's non-hemolytic, and it's rapid growth. So what should be the next step? Keep in mind that your original gram stain was gram negative. So wouldn't you want to repeat your gram stain to confirm your suspicions that it's probably just decolorized? Yes. However, you're going to want to make sure that you take this over to the biosafety cabinet and repeat that gram stain there. All right. So here is the gram stain that if you would have reviewed the gram stain from the night before, they might not have seen the spores quite so much, but this is maybe what you would see in culture. They certainly would have seen the chaining from the gram stain the night before. So therefore, we're able to confirm that it is decolorized, it is truly a gram positive, that you see subterminal spores. Well, what does that mean? A lot of gram positive rods have spores. Well, sometimes you see spores that are terminal, meaning they're at the very end of the organism cell itself. So then they have these big bulbous ends look to the end. And so here, however, the spore is subterminal. There is no significant swelling of that particular cell. Essentially, that cell is the same size as one of the cells without a spore. So the number of spores increases with age, as we know. That's how spores or organisms protect itself. They sporulate more with the age. So you know that this is probably a very hazardous organism and that you don't want to do a whole lot of workup with this. So you're all along thinking gram-positive rod, possibly decolorized, subterminal spores, no swelling of the cell. The spores increase with age. And so look back at your summary pages. Review those again. Does your gram stain look just like this on the left, or excuse me, the right-hand side, again, where it's chaining? Now, if there are not very many organism in there, you may not be able to see that characteristic. They might be far and few, but again, they're still large. So know that you now need to go to the tab that's labeled gram-positive bacilli in our bench guide. And there it will tell you what biochemicals you should work on. And I will show you that in a moment. So any organism that is rapid growth like this, non-hemolytic, if you have it well isolated, if it looks flat, slightly convex or irregular edge, that if it has that curling tail, that camal projection, that's called the medusa head. Some people call that rugged or rough appearance, colony morphology, ground glass. The most critical thing that this particular organism does is when you go to touch it to repeat that gram stain, if it acts tenacious, if it acts sticky, if it sticks to your loop, it's when you go to pick up your one colony, then and it acts like a beaten egg white. That's a clue that you might have this particular organism. All right, so according to the LRN protocol, what else is recommended for testing? One of the first tests you should do in that flow chart is the catalase. And I just want to show you here very quickly how that works. So in the biosafety cabinet, you would take a few drops of your catalase reagent, put it into the tube, and then take a loop of organism, maybe even several colonies, but do not put it down into the liquid. Just smear it to the side above the liquid, but don't let it touch, because once it touches, it's going to start aerosolizing. You want to add your cap next. So add the cap next, turn the whole tube so that the media runs onto the organism and creates bubbles. Well, I've stood the tube back up for images, and you can see in this very last image all the bubbles. So this tends to be a really nice way to visualize catalase production. All right. So yeah, you're going to do the catalase and then also the tube motility. Those are the only two recommended. Motility is done in the media that we provide, or if you want, you're welcome to use the commercial media, but especially with the commercial media, make sure you do a positive and negative control, because they are harder to read. So here in this slide, you'll see a positive and negative to the right side. And you can also see our in our bench guide what we recommend, that initially you take it to the biosafety cabinet, you repeat your gram stain, and if you suspect all those characteristics, then you'll take it to a tube catalase. And from there, go ahead and do your motility. If your motility is negative at 24 hours, you will want to talk it over and talk it over with your supervisor first, and then give Nebraska Public Health Laboratory a call. So just as a review, this is the APHL bench guide that is available on our website. It's got a few more images that you can look at. They talk about colony morphology. And again, they recommend only the catalase and the motility here too. What is of interest though, is that this year APHL added something new. They are now trying to recommend that laboratories look for something called Bacillus cereus, the biovar anthracis, which can look very much like a Bacillus anthracis, but truly are two different organisms. Well, this is interesting because this is throwing a whole loop into our flow chart of doing the catalase and the motility. And why is that? They're saying that the Bacillus cereus, most bacilluses are hemolytic, and they don't have a capsule, and they're also motility positive. So normally the B ceruses we are able to rule out. And remember, this is an organism that causes food poisoning. So if you're asked to not necessarily culture the food, but a patient might be positive and systemic, they're worried about Bacillus cereus. However, Bacillus cereus biovar anthrax, which they have discovered is non-hemolytic and is possibly non-modal. So what do we do? This does throw that wrench into our flow chart. For now, here in Nebraska, we are following the old flow chart. This is an organism that has not been seen in the United States yet. It's been seen in Africa, as it mentions here, right under the capsule line. So I suspect if they're worried about it, they're worried that someday it will get to the United States, but currently there has been no report of it. So therefore, we continue to ask our laboratories, our LRN laboratories, to do both that catalase and bacillus, or motility. All right. With that, I wanted to just go through a couple more things. The other morphologies that the organism can have, it may not necessarily look perfect. It could look like this, where it was nice and smooth and only the very edge has that ground glass appearance. So if you question it at all, please do your rule out method. So obviously the organism we're looking at here is probably anthrax. We know anthrax is causing a clinical presentation that can look like a couple of different things. It can look like it's cutaneous. It can be inhaled, causing a disease called Wolff-Sorter's disease. And it can even be contracted through the gastrointestinal by eating raw foods. I'll go through these more in depth. Where do we get this organism? Well, in reality, it is a zoonotic disease. It comes from cattle, from sheep, from goats. You can acquire it by simply coming in contact with contaminated soil. You can get it from the air. And it doesn't have to be what we would worry about, a bioterrorism event. It's seen somewhat commonly, not an everyday event, but seen in the Midwest, in Minnesota, in South Dakota, North Dakota. They've seen it in the past in their cattle yards. So it very much could be a situation where only one patient comes in. Now, on the other hand, all of a sudden you have 2 or 3 patients and they all have the same looking organism. It's definitely a clue that there is a problem here, and it may be more intentional than environmental. So if we're talking about the cutaneous form, what the physician probably is looking for is that what we call a vesicle that develops into an eschar. So it becomes more black as time goes on. The spores have embedded themselves underneath the skin, and they take a day or two to develop this small papule. Eventually it becomes black. Very painless, but still it probably looks worse than it feels. Something like this is dangerous and should be treated immediately because it can spread to the blood system, to your respiratory system. And even a perfectly healthy person, if left untreated, could die from this organism. Now, if you're able to get the patient on, or you as, I mean the physician, could treat this patient immediately with a penicillin, more than likely they'll survive. The death rate is very low here at 1%. The big thing to remember is that this is rare person-to-person transmission. All right. The gastrointestinal type of disease is usually occurring when there's consumption of undercooked meat. We Americans like our beef raw. Farmers tend to butcher their own cattle. So it's definitely something that they need to be aware of. What happens is the patient starts vomiting, you see fever, abdominal distress. So it has an intestinal eschar, just similar to the lesion you saw, but normally you can't see it unless you do exploratory surgery. This type of disease is very, not contagious, very dangerous. Its mortality rate tends to be very high, even despite treatment, and very hard for a patient to survive. So what you're going to see is you're possibly going to have positive stool culture as well as the blood culture. The last one, inhalation. I want to tell you that this is probably very rare. However, it is the most lethal form, even more so than gastrointestinal, and most likely to be used for biocrime. And what I mentioned before as being covertly or purposely targeted would be a biocrime. Now, the infected dose for naturally occurring anthrax spores is usually quite a few, anywhere from 8,000 to 40,000. So that means if that cow in that field took up more than 40,000, it's likely that cow might turn up to be infected. Unfortunately, back in 2001, someone discovered how to weaponize this organism. They made it so small and molecularly changed its genetic structure to make it so small that even 10 to 100 spores could easily make it into the lungs. And in just one day or a couple of days, it would infect a patient. So you're talking a malaise, fever, fatigue, the x-ray for any of you rural sites that do x-rays. They have what are called the widened mediastina, which is supposed to be represented by this x-ray image. I'm not an expert to point out what that mediastinum looks like, but what can happen is there is abrupt respiratory distress and death even early on. And unfortunately, by the time it gets this far, antibiotics doesn't usually help. Again, no person-to-person transmission. And why do I really point this out? Because back in 2001, when people were opening their mail and they had white powders in their mail and suspecting anthrax, the person who was in the, if this person went to the hospital people wouldn't even treat them. This is not something that can be transferred from person to person like our coronavirus is today. So there's no fear of contracting this in the hospital. So a quick note on Amerithrax is what they called that incident back in 2001. It had a fatality rate of over 45%. Granted, there were only 22 people that were infected. 11 of those were contagious, 11 of those, or cutaneous, I'm sorry, and 11 were inhalation-wide. But if you think about it, I believe 2 to 3 of them died. But what workup came about because of all of that was astounding. They said that over 350,000 specimens were sent to their state labs, that over 10,000 environmental samples were tested by the CDC from the post offices, the Washington buildings, and the field officers. 32,000 people received prophylaxis, and it took over 600,000 investigator hours to work this whole thing up. So the lessons learned in all of this is that a majority of specimens back then, 1999, they just had barely started to teach the LRN protocol. And amazingly, the very first laboratory that discovered this anthrax-like attack was a laboratory who had just months before gone through the LRN protocol and literally recognized it. God knows if that hadn't happened, more probably would have been killed with this attack. So what was happening is majority of labs who did not have testing just sent every gram-positive rod into the laboratory, into the state labs. So it's important to remember that you can, with this rule out and refer process, you can avoid costly molecular testing, and for us as laboratorians, and can avoid a lot of risk to you as the laboratorian. Again, there's the flow chart again to recommend what how to follow it through, and if you cannot rule it out, what you would do with it. I know we're on the top of the hour. However, I want to take a few more minutes just to talk about some other morphologies. I'd like to compare, on the left is an anthrax strain compared to something that we see in the laboratory quite frequently, and that would be our contaminants, our plague contaminants. So you see these very mucoid, ugly, globular organism, sometimes even on plates that are not inoculated, let alone on inoculation plates. So that kind of morphology, I think you could just from the morphology itself rule it out. However, if you're questioning it, because even here at the very edges on the fourth quadrant, you'll notice it is kind of rough colony. So yeah, I would be totally okay that you question this and then ask for our consult as a public health laboratory. Same way with the gram stain. Make sure that you have a reference box that if you question a Bacillus anthracis, you can pull out other gram-positive rods. So you could pull out diphtheroid to make sure it's a lot larger than that. You could pull out other Clostridiums. In reality, the one slide on the left is Listeria, which sometimes we send out as unknowns, and people will think that that's an anthrax simply because it was sent out on our anthrax challenge set. So keep in mind the size is very important. Now, there's a lot of mimics to Bacillus anthracis. One of them that is called Bacillus anthracis stern strain, which in itself is an inactivated anthrax. So it looks exactly like. Now, here's something that I would be very suspicious of if on the left-hand side, if you were working that up. Again, here's another mimic. This is stern to the right, and to the left is probably another Clostridium or Bacillus species that it would be impossible to rule out just by colony morphology. So to share with you, I took this case study from something that happened back in 2000 that a farmer had noticed in Minnesota, that 5 of his cows had died. And in fact, he had apparently also butchered one of his very lame cows and used that for meat. So this happens in our Midwest area, and we as laboratorians need to be on the watch out for this. So who do you call? Well, first off, definitely let everyone know in your laboratory what you suspect, so everybody is aware and they can correlate it with other specimens to the same patient. Also let your supervisor know, have them confirm what you're suspicious of. Once that is the case, go ahead and let us know. We would prefer that you let us know using your stat pack instrument. I know that during the COVID season, we have lapsed a little and some of the systems are down. But that is the best way to show the colony morphology and the gram stain morphology to us so we can make an educated decision too about it. You may even consider notifying your laboratory, or excuse me, your physician about this, that you're sending it in. And then along the way, at some point, we'll assist you in notifying the county and the state epidemiologist. I'm going to take a real quick browse through packaging and shipping. So to remember that it is state law. It is required to follow through because not only state law, I mean it's federal law, and we want to make sure that everybody is safe who handles this packaging and shipping, and you as a shipper are liable for any problems if it's not packaged properly. Division point 2, packaging and shipping, encounters both category B and category A. Both of those require triple packaging, which means that not only do you have to have the specimen in some sort of a tube or whatever, it has to be in a biosafety bag, or excuse me, a biohazard bag, which is your secondary watertight receptacle, and then a rigid outer packaging. A lot of paperwork to go with it, including shipper's declaration. I won't get into a whole lot of detail with that, but it's required of any category A that you would ship to us. If you're shipping by ground, the only way we accept category A by ground is if you're in Lincoln and Omaha. So do know that that has a shipper's declaration as well. We don't call it declaration, but it is required for a category A. For those of you shipping ground, it is also required that you send us the Guide 158, which serves as an MSDS sheet because on the back it has the spill instructions. So any courier that notices a leaky box is going to freak out. They need to carry this. You need to give it to the courier in person so they have it on their person, that if they have a leaky specimen, they can look on this to see what to do. All right. Reportable diseases, as you know, these BT organisms are listed as category A, are reportable. We will assist you through the CDC forms. Just for your information, I want you to remember what each of these forms are for. So Form 2 is initiated by NPHL, and it's to transfer a confirmed select agent. So if you happen to confirm your organism on your MALDI-TOF or any other molecular PCR or sequencing like instrumentation, that is confirmation enough that we will have you fill out Form 2. Now, Form 3, you only would fill out if you had an exposure. And what that means is if there's some criteria to what you consider an exposure. That would be if opened at the bench level, even to do a gram stain. Unfortunately, it's considered to be an exposure. And you want to report this because you want to make sure that you're safe and you're protected through therapy as well as all your staff. Form 4 is probably the biggest form that you'll have to fill out, because what that form is it simply says that it has been confirmed by the public health laboratory. You suspected it, but you've sent it to the public health laboratory. They've confirmed it. And so you're now asked by us to fill out this form and send it directly to the CDC. So do know your forms. That is very important, but we will assist you. With that, that ends our session 2. I'll open it to any other questions you might have, and then with this, I'll give you your code so you can apply for your PACE credits. Any question, Brandy? Or Julie? Or Sandra? Or I know I missed a couple of you, but from Methodist, Victoria. All right. Tell me if you're ready for that code then. So, instead of saying it, I think I'm going to put it in the chat box. Oops. So let me go ahead. Oh, that's why I'm in the wrong chat box. So your code is this, and that will cover for session 2, called the Rule Out and Refer. That will give you 1 credit hour. Can you all see that? Go ahead and type in yes if you got your code. And there's the code. Great. Thank you, Methodist. Julie, got your code? And Brandy, I just wanted to make sure you guys got your code too. This is recorded, so that's why I'm not trying to be too secretive, but I want to make sure that they all get it. So, do I hear from Brandy? I'll hang on for a minute or two to make sure she has it as well. So, oh good, all right, she's gotten it too. All right, we will see you next Tuesday. Again, we will go through session 3, which will be our final didactic before our challenge sets are sent out. So hope you guys have a great day and rest of the week, and take care. If you have any questions, let me know. Much appreciated. Bye-bye now.